Good morning, everybody. Welcome to the HIV Center Grand Rounds. Usually you see Bob Remien here, but he is not able to connect because of power issues at his home, so you'll have to do it with me. My name is Theo Sanford. I'm the director of the Development Core, and I'm very happy to introduce our speaker for today. But before going there, let's make some announcements about upcoming Grand Rounds. On May 5th, we have a duo presentation. We have Samantha Stonebreaker, who will talk to us about a digital tool to improve HIV-related clinical communication. And the second speaker that day will be Ofola Mbago, who will be talking about immediate ART and HIV stigma and medical mistrust. Those are results from the pilot study that he did with funding from the HIV Center. On May 19, we have Valerie Earnshaw, who will talk about substance use disorder and HIV stigma. Then on June 2nd, we have two alumni from our postdoctoral training program, Stephanie Marhevka and Jose Bauermeister. And then on June 23rd, the last grand rounds of this academic year, we will have Ken Mayer, who will present updates on PrEP. And at that grand rounds, we will also award the Early Stage Investigator Manuscript Award from the HIV Center. So those are the upcoming rounds. Then it's my great pleasure and honor to introduce the speaker for today, Dr. Lisa Eaton. She is professor in Human Development and Family Sciences at the University of Connecticut. And her primary interest is in social determinants of disease, and more specifically on the multi-level impact of stigma and linkage, access and retention to healthcare among diverse populations. Dr. Eaton is incredibly well published. She is very successful in obtaining research awards from the National Institutes of Health. And of course, she is where she is because of the mentorship that she has received. She does it herself, of course, but she acknowledges her mentors and the people from which she learned. But she also pays that mentorship forward to her students and her mentees. And in addition to being a teacher and a mentor, she's a researcher, a teacher, a mentor. She is also an extremely experienced reviewer of NIH grants. And on top of that, she is an associate editor of AIDS and Behavior. And sometimes you meet people and you wonder, how are they able to do all these things? And Lisa is one such person. The first time I heard about Lisa was in 2008. She applied to our postdoctoral training program, but before we could offer her position, Yale University has snatched her away from us. So I'm very pleased that I can finally say that we have her, even if it's only for this current rounds. Lisa, welcome. The floor is yours.
Thank you so much. That was so very sweet of you. Yeah, no, and it's great to be back. I do remember my visit very, very fondly. And even if it's virtually, it's great to be back. And I was so very excited to receive the invitation. So please keep me in mind for future grand rounds as well. Okay, so let me just grab my, now I'm just not sure if you can see my screen.
Yes.
You're okay, so you're able to see the correct screen, the screen I'm supposed to be on?
Yes, we do.
All right, perfect. Awesome. Okay, well, thank you all. Again, I'm really, really grateful to be here. I was super excited to receive the invitation to present. And yeah, without further ado, so the title of my talk is Expecting Change Without Affecting Change, Interventions to Address Stigma and Healthcare Disparities Among Black Sexually Diverse Men. Oh, come on. Okay, there we go. Sorry, I'm just figuring out how to move the slides. So I first just want to acknowledge that we have recruited thousands of individuals into our studies, and I am absolutely eternally grateful for their thoughts, feedbacks, feelings that they've shared with us. I'm also very grateful for community-based organizations for providing direct services to the participants that we work with, and the policy-based organizations working to impact systemic change. Numerous collaborators and co-authors. I'll mention some of them today, but there are many, many more collaborators and co-authors who I'm very grateful for. Of course, the National Institutes of Health have provided funding for our research. So I'm grateful for the program officers and reviewers and directors who are sponsoring these programs of research. And I have no disclosures. So an overview of my presentation, I'm going to kind of briefly present on HIV incidence and prevalence among Black sexually diverse men or Black sexual minority men. I know that I would imagine that most of y'all in the audience have familiarity with this area, so I'm just going to briefly touch on that and basically just say a little bit about the prevalent, or actually the incidence data, prevalence and incidence data that we've collected from our own studies. And then I am going to do a little bit of an overview of stigma. So I know that stigma is a very popular area of HIV prevention, of the social behavioral HIV prevention and treatment research. I do want to just kind of do my own little overview to give you an idea of how I kind of brought things from like a theoretical framework to actual practice. I think it can be a bit helpful to see that whole stream because talking about stigma can be very abstract. So I think it's helpful to see kind of the nuts and bolts of it and kind of like behind the scenes on people's thought processes on it. And then I'm going to tell you a little bit about some interventions that we've developed to address different components of stigma. And then I'll wrap it up with future plans. All right, so for our specific work in HIV prevention and treatment, just a quick background on me. So I've been doing this work since like my undergraduate years. I've been working primarily in HIV prevention. I started out with an interest in global health. But that actually, well, global maternal alcohol used to be specific, but that actually merged into an interest in domestic HIV epidemic. And I was given the opportunity to work in the southeastern US, in particular, the city of Atlanta. And I could not believe the prevalence, the HIV prevalence data that we were collecting was very alarming. So it's been fairly consistent that when we do kind of these broad outreach surveys across Atlanta and in some cases throughout the state of Georgia, that we see a self-reported, we see about 35% of our participants will self-report living with HIV, which is of course very concerning, it's very high. And then in our longitudinal studies, we see an annual incidence of around 5%. So in our own data, I mean, we understand, I think, you know, there's been a considerable amount of attention on HIV transmission among sexual orientation and gender diverse populations. But this is also specifically what we see in our data, what we see in Atlanta and also throughout the state of Georgia. And most recently, we've started moving into Alabama, South Carolina, North Carolina, Tennessee, and Florida. So and I should say this too, that a lot of our research is, so we don't work in a clinic. And one of which mostly comes with a lot of challenges because it would be nice to be in a clinic to kind of like have an active audience being in a clinic, but we don't work in a clinic. And so one of the challenges of not working in a clinic is that we have to recruit all of our participants. But if you're working with individuals who aren't actively involved in healthcare, you are also arguably working with individuals who are potentially at greatest risk for HIV or HIV-related complications. So anyways, I say all that to say that we are working with individuals who are either living with HIV or who are at fairly elevated risk for HIV transmission. So what is going on, and why are we seeing such high rates of HIV transmission, particularly throughout the southeastern US? And there are a lot of different areas that can be focused on. and I don't have time to go into all these different areas, but the area wherein I'm most interested in is this relationship between individuals who are potentially at risk for HIV or who are living with HIV and what their access to healthcare looks like. And so we know that access to healthcare is the inequities, particularly the ethnic and racial related healthcare inequities, are a key driver of the HIV epidemic. And there are many ways in which these key inequities manifest themselves, but in particular, I'm focused on stigma. So, and I think of stigma as an emotional barrier. There are a lot of logistical barriers to accessing healthcare that lead to healthcare inequities, but I'm more interested in the social emotional barriers, in particular, the barrier of stigma, or at most, the combination of logistical barriers and emotional barriers, inclusive of stigma. And so just a couple of studies I'd like to highlight in this area. One is by work with a colleague, Sarah Calabrese. She did this study, it was from 2014. It was one of the first studies where we looked at stigma, or where she looked at stigma in prescribing behaviors for Black sexually diverse men. And what she found was that providers were more likely to see Black sexual minority men as likely to engage in condomless sex if they were to be prescribed PrEP, and then therefore in turn not prescribe PrEP. So it's like this very clear discriminatory behavior that was identified in the work that she did. And also, I want to highlight work by Christian Chandler, who was a postdoc, and we worked together for a long time, and who's now at Vanderbilt University, has also has a series of papers in this area focused on stigma, and really in regards to the lack of HIV testing uptake in particular. So when you look at the HIV care continuum, particularly among Black gay men, we see this like real drop off in terms of like being aware that testing for HIV is important, but actually testing regularly for HIV. We're seeing low rates. We're seeing rates lower than what we need to be seeing. Even though, and stigma is frequently cited as the main barrier to testing. I think too, sometimes I come across articles that really kind of summarize succinctly, I think, in a way that's kind of easily digestible for people to follow. I think this article in particular, this was published a few years ago in the New York Times Magazine, America's Hidden HIV Epidemic. What I really appreciated about this story in terms of understanding the racial and ethnic healthcare related inequities is that these inequities, so that the epidemic has been moving very swiftly across certain subpopulations of the US, but has been more halted among other populations. And what's happened is, in particular, among our Black gay men, among our Black trans women, among our non-binary populations, particularly throughout the US, the work and the attention has really very much been under the radar. And I think, it's kind of alluding to why I like frame my talk, or the title of my talk being Expecting Change Without Affecting Change, kind of alludes to this issue, which is that the HIV epidemic for decades was continuing without a proper response for certain subpopulations in the US. And now we are and I think, a lot of really good people were doing a lot of really good work for all those years, but that work wasn't getting the political support that it needed. And I think probably around 2010, I noticed this, having started in this area prior to 2010, I noticed that in about 2010, like the CDC said, hang on, like we have, there's a lot of concern, particularly among our racial, ethnic, sexually diverse populations throughout the South. We are seeing very high rates of HIV transmission. But so that additional focus was very important, but was very late. And so this article kind of makes a point that, like, in some ways we're kind of like moving a bit through quicksand and trying to play catch up with like decades worth of unsupported programmatic efforts to help people who are living with HIV or who are at risk for HIV. I think the article too really, brings to the surface some of the systemic racism, some of the systemic failures of being able to put together a comprehensive response to the HIV epidemic, particularly among individuals in the South. So anyways, I think it captures things, says somewhat succinctly, an area of research or social concern that can be hard to articulate. Just make sure I stay on time too. Okay. I think, getting back to what I was saying before in terms of like seeing, I've been told that it's helpful to see things kind of like from the beginning to the end in terms of like putting together a stigma focused intervention. So usually where I start is by saying like, well, what exactly is stigma and are we all on the same page? And stigma can be defined in a lot of different ways. So here's how I do it, which is very like very consistent with the historical perspective, that stigma is an attribute that is deeply discredited by society and results in rejection. I think what's really interesting is that we see that all societies stigmatize some conditions and some behaviors because doing so provides for group solidarity by delineating outsiders from insiders. This is like a very fundamental part of human behavior. So I'm a social psychologist by training, which means that I really enjoy understanding how people behave in groups and how groups form, and groups form for protection and solidarity and shared culture and a sense of security. So it is like a natural human behavior to want to form groups. It just so happens that the formation of groups can be the result of a stigmatizing process. So, and that's just what it is. When something is, in order for something to become stigmatized, it goes through a process. It gets labeled, stereotyped. Individuals who harbor this attribute are disconnected, they lose status, and then they are discriminated against. This process is what leads to forming in-groups and out-groups, and that is the desire to form in-groups and out-groups is a fairly fundamental part of human behavior. Okay. So going from these like historical perspectives, these broad definitions of what stigma is, how exactly do you kind of like whittle that down to, well, what do I actually do about that in HIV prevention and treatment literature? And I think one of the issues in the stigma literature in healthcare is that people define stigma in a lot of different ways, and people will put together measures in particular and call them all sorts of different things. So, and I'm not here to critique that, I'm just here to show you what I do. And this is definitely in collaboration with a very good colleague, Val Earnshaw. Val Earnshaw and I have worked together for a long time. It sounds like Val will also be presenting here too. So Val's helped me out with this, basically in the research operationalization of stigma. So based on some of her models, what we do is we focus on stereotypes, which are group-based beliefs, prejudice, negative emotions and feelings, discrimination, expressions of prejudice and stereotypes. So it's these three items, it's the stereotypes, prejudice, and discrimination that are thought of as the items that are basically supporting stigmatizing environments. So what that means is that these are the actions, beliefs, behaviors that people who don't necessarily harbor that stigma are engaging in to support that stigmatizing environment. Now, among the individuals who are experiencing these things, they experience internalized stigma. So the internalizing of these beliefs that they're hearing, they experience enacted stigma, So that's being on the receiving end of that discrimination and anticipated stigma. So being concerned about the potential to be mistreated in the future. So I really kind of compartmentalize, like, there's the environment wherein stigma occurs, and these are the things that support it. That's the stereotypes, prejudice, and discrimination. Then there are the experiences of the individual, which is internalization and enacting and anticipated stigma. Okay, so that's like the kind of my most straightforward way of like saying, like, this is how we put it together. I also want to, there's also a couple of important points that I think are really relevant here. And it gets a little bit to like future work that I see myself doing. So, and I call this, so I'm very interested in the area of microaggressions, because I can tell you that when I look at models, when we run measures, and when we use the framework that I just showed you, and we ask about discrimination and stereotypes and prejudice, a lot of measures of discrimination are big things. It's things like things that would cause a lot of upheaval, like I lost my job because of HIV status, or I was kicked out of my house because of my HIV status. They're big events. And these things do certainly happen, but they're not very frequently reported. Or they have been, or they are reported, but they're like events that may have occurred like 10 years ago or 20 years ago. And so we thought, well, what about, like everyday hassles of experiencing stigma? And that kind of led us into this area of HIV, of developing a couple of scales around HIV-related microaggressions. So we have one scale that is looking at for an individual who's living with HIV, it's looking at the HIV-related microaggressions, and that's very predictive of multiple health outcomes. Another area of this, though, is kind of the flip side. So one of the things that I felt that the stigma literature has been missing for quite some time is, and I see this as missing in the literature quite a bit, or excuse me, I see this as missing in across different methodologies. So I see this as missing in intervention research and in cross-sectional surveys and longitudinal studies of stigma, is that we tend to focus on people's experiences of stigma. But that says nothing about people who are perpetuating stigma. And so this is an area of research that I'm definitely looking to grow. So I call this HIV-related perpetuated microaggressions. Things like people living with HIV should limit their sex partners to other people living with HIV. Or I would have hesitations about having sex with someone who was living with HIV. Or I would have hesitations about being in a long-term relationship with someone who was living with HIV. And this scale is associated with other stigma-related items. I think it's kind of critical in expanding this framework forward, because we are definitely stymied by this kind of like very pure focus on the experiences of the individual. And just to be clear, so something like microaggressions perpetuated microaggressions would be considered a form of discrimination, because that is, someone without this marked attribute projecting these negative experiences towards others. Whereas if the scale of HIV microaggressions, experiencing microaggressions would be considered an enacted stigma. So it still fits into that model that I just showed you. It's just kind of an additional area moving forward that I know that I'm particularly interested in. And these scales have been very robust in measuring, I think, very important areas, very important health outcomes. So I'll be publishing more on that in the near future. I also think it's important to highlight that there are a couple other areas of stigma that don't necessarily fit neatly into the model, but I think are really critical in understanding, and particularly in understanding HIV prevention and treatment related stigma. So one is stigma by association. So most of my work is with pre-exposure prophylaxis, or PrEP. And what's been really interesting about working in the area of PrEP is that when PrEP first came out, there was kind of like this immediate like, but wait a second, this is an HIV medication, and like people are going to think I have HIV, and that's stigma by association, or at least that's how I conceptualize that. And there was, I don't hear this, I don't really hear this now, but I definitely heard this around the time of the FDA approval meeting, that there was pressure, kind of like, well, can't we make Truvada, like, can we make the pill a different color? We can call a different name. Can we do something to change things? And I think it's just important to appreciate the social components of how that was rolled out, because it's a good example of this type of thing. And how we deliver this information doesn't happen in vacuum. People really do have these cognitions, and that the stigma by association can certainly serve as an emotional barrier to accessing PrEP. So it's not trivial. Now, there was also another area that's been important in my research is what I call stigma in transition, or is what is referred to in the literature as stigma in transition. And this is the movement basically between seroconversion. So in this particular case, so we do research with individuals who say, who either report to us that their most recent test was HIV negative, or that they are that they've recently tested HIV negative, and then maybe a couple months or so later they test HIV positive. And what does that do? How does that impact their perceptions towards these stigma items? How does that transition of status change? How does that health status change impact those stereotypes, discrimination, prejudice, and the development of internalized, enacted, anticipated stigmas? What happens there? So that's been a very interesting area of my research, kind of historically speaking, and I'll tell you a little bit more about that in one of my studies, one of my kind of formative studies leading up to intervention work. I also think it's helpful to kind of always do some self-reflection in terms of like how stigmatized and how healthcare is potentially contributing to stigmatizing environments. And there's actually just a great article on this in Pause magazine, I believe it came out this week, kind of getting right to these actually both of these points that I'm going to mention here. One is, I think a lot in many ways we've moved away from framing things like hard to reach populations or hidden populations, but at the same time, we still do hear these things being said. And I just want to, I do want to highlight work. So Red Driver, who is at the HIV Center, and Kay Simon, who is a postdoc at UConn. We've been working together on this area of, in particular, around medical mistrust. So one of the concerns in how public health responses have historically framed working with diverse populations is that these populations can be hard to recruit, hard to bring into study settings. And one of the ways in which I respond to that, or I was trying to respond to that, is to say, yeah, but like, okay, but the focus really needs to be on like, what are we doing as providers that is leading to this environment? And one of the areas that really, in a lot of ways, kind of started my career in this area was focusing on medical mistrust and conversations around medical mistrust, and really like honestly asking ourselves, well, why is it that people don't want to show up for healthcare? Why, like, how does somebody get into that situation? And the conversations around medical mistrust, when you have those with participants, are very, very rich and very informative, and work with Red and Kay and myself and others in my lab group are forthcoming on this area. I also think it's interesting to point out the messaging around U equals U, so undetectable equals untransmittable. This has been a really, from the perspective of a social psychologist and someone who's very interested in stigma work, this has been a really interesting area to see unfold, because a lot of the literature that initially came out about U equals U was really focused on how U equals U was removing stigma. And I agree with that people living with HIV should feel like if they're undetectable, they're not going to transmit HIV, and that should be destigmatizing. But what was also kind of going on in the background was this this gain of status for people living with HIV who were able to achieve an undetectable viral load. But when you kind of go back to like the process of stigma, as you create a group, as you create in groups and out groups, you also create status. So what's interesting here is that we also know that there are individuals who, for at least a couple of reasons, can be living with HIV and have a detectable viral load and won't get to a place where they have an undetectable viral load. So that's created kind of like this interesting status loss and kind of like stigma in process, kind of right before our eyes in this very area, in our very area of research. I think this too, I mean, this is kind of a real nuanced example, but I think it's important to mention. And anytime I kind of look back on this data, I just think like, wow, what are we doing? Like, this is kind of a lot to process. I had added a measure of concerns for testing HIV positive to one of my studies. And this is it's a 8-item measure. I just pulled a couple of measures here just to provide an example. And I was really surprised at what I saw, because when I initially picked up the measure, I thought, oh, no one's really going to agree to this, but sure, let's just try it. Let's see what happens. And actually the agreement with these items is really, really high. So things like, and again, this is all with Black sexual minority men in the Atlanta, Georgia area, who are reporting to us that they are not living with HIV. But things like asking the question, I worry about getting infected with HIV a lot of the time. 17% of people say that. Or sorry, all of the time. 17% of people say that. A lot of the time, 10% of people say that. A moderate amount of time, 16% of people say that. Getting HIV is something I am extremely concerned about. 27% of people say that. Or concerned about a lot. 17% of people say that. And so it got me thinking that like the messaging around HIV, around the need to be concerned about HIV transmission, could in and of itself also be creating quite considerable stress, and could also be creating a stigmatizing environment as well. I mean, when I look just, purely at these data, I think to myself, like, okay, like clearly like the message is out there that it's important to know your status. But it also appears to be very, very stressful, because to be, for 27% of people reporting that they're extremely concerned about getting HIV, as a researcher, I have to stop and ask myself, how did we get into this situation? Because there are good options for HIV prevention. Like, what is going on? This, to me, this just says that there are potentially concerns about stigma coming from our public health messaging, and that it's important to look more closely at this. And also, this measure that we use, the self-perception of HIV risk, is actually quite predictive. We ran a couple of multiple mediator models, and basically what we found is that this self-perception of HIV risk does predict, it has serious consequences. So it does predict longer time since last HIV test, and a longer amount of time having passed since last routine medical exam. And these things are moving through depression and HIV status avoidance, not wanting to know one's HIV status. So I do think that I've seen enough data to suggest that we really have to start. It's very possible that the messaging that we're producing, our public health messaging around the need to test for HIV, I think needs a very serious refocus and a lot of consideration on how these messages are landing on people. Okay. Okay, so what exactly can we do? I'm sorry, I'm just trying to keep track of the time as we go. So what exactly, so stigma is defined, stigma avenues are understood, it's operationalized, at least according to how I do my research. So now what? Okay, so one thing that I always like to take a little pause in this regard, because so I've just mentioned a lot of things, and a lot of it can feel really overwhelming, particularly when I think we all know that like the root of things is systemic racism, it's historical injustices, it's these areas that maybe there's somebody out there who can fix that immediately overnight, but it's not me. And so I think that I think it's really important to just take a moment to put it into perspective and really think about like, well, what can we do that could potentially be meaningful here? This is a conversation that I do tend to have with graduate students or junior faculty about how I've processed these things. And so I say to myself, like, okay, I'm not going to be able to solve all of these things overnight. It's just not, this is not a problem that was created by one person, and it's all in all likelihood not going to be solved by one person. And it's not a problem that, it's going to take time. But that also doesn't mean that we do nothing. For me, that means that I focus on the pieces that I feel like I do, potentially have some control over. So anyways, it's just my moment to just say that I acknowledge that like a lot of the things that I've mentioned are major, require major fundamental change. I don't have that major fundamental change, but I do have my contributions, my, the small pieces, the areas where I see that I can make a difference. And I hope that, if enough people also feel similarly, then that all of that can add up to something very meaningful. So it's just my kind of quick pause. Okay, so getting towards the groundwork for and into some of the stigma interventions that we've developed. We did, or sorry, excuse me. So again, as I mentioned, I work with Val a lot, who's helped me think through these stigma messages quite a bit. But that's very specific to the components of stigma. What's also helped me is to use the modified social ecological model. And the reason why that's helped me when I moved to intervention development is because there's just so many different avenues. There's so many different potential, how stigma permeates our healthcare system is very multifaceted. And so you can take a public policy approach, you can take a community structural approach, you can look at social and sexual networks, you can do individual level work and do group level work. And so I think that having, and I've seen, I think I've actually seen all of these strategies come to fruition too. So there are a lot of different levels where you can say, here's where I'm going to like insert myself. A lot of the work I have done, what I'm going to tell you about, has been focused either at the structural level or at the individual level. My background, I have a lot of background in counseling. So that's how I ended up getting kind of mostly into the individual level. I think the public policy level though is fascinating. And I think there's a lot of work that can be done there. The other areas that I've always been really excited about are working within healthcare systems, working within healthcare agencies, and doing a lot of like self-reflection on like, what do your how does your outreach work, and like how are these messages landing on people? And I think those are also very exciting studies. But so anyways, the point is that you do kind of have to settle on like a level wherein you're interested in primarily focusing on. So one of the first studies that I did, just to kind of like set the groundwork of like, are these things really occurring as we think they're occurring? We enrolled, and this was a few years back, we enrolled 153 Black sexual minority men into a longitudinal qualitative and quantitative study to assess their experiences of stigma when linking to care. What's interesting here is that we looked at individuals who had tested HIV negative with us or STI negative with us, but a subgroup. So the larger study was 500 individuals. Of that, 153 had tested, of 153 individuals ended up testing positive during the course of a study. 50 of those individuals tested positive for HIV, and 103 of those individuals tested positive for an STI. So we followed those particular individuals who had tested positive. So we had their prior scores and their scores after testing positive, and we looked at their experiences of linking to healthcare, and we looked at their experiences of stigma and linking to healthcare in the year after having been diagnosed. And here's what we see. And basically, kind of in a nutshell, the point is that individuals, so we sorted individuals by being either inadequately engaged in healthcare or adequately engaged in healthcare. And that was based on the number of appointments that they reported to us. So individuals reporting more, individuals who were inadequately engaged in healthcare were more likely to report a higher number of experiences of enacted stigma from healthcare providers than individuals who were adequately engaged in healthcare. So we do see these things. So things like enacted stigma really do have important implications for actual health outcomes, in this case, accessing healthcare. And then we see the same thing with anticipated HIV stigma as well. Those who are inadequately engaged in healthcare over the course of a 13-month period, we see them as being less likely to, we see them as reporting a greater number of instances of enacted stigma. Okay. So we've defined things, we've kind of laid the groundwork for some things that that we know to be important in this area. So now I'm going to tell you about a couple of our major studies. So Project Link was a 5-year study. It's actually still going on, focused in the Atlanta, Georgia area. We recruited around 480 participants for this study. And this was what we call a 2x2 factorial design to test an HIV STI delivered. Let me back up. So in one arm of the study, we tested offering HIV testing appointments either online through video chat, just like this. So we would send individuals test kits, and then we would provide HIV test counseling through video chat. So individuals were taking tests at home, but they had a live counselor during that process. So we tested the likelihood of individuals showing up if they were offered an online appointment versus if they were offered an in-person appointment. And then we also offered either stigma-focused counseling, and I'll tell you the details about that in a couple of slides, or a time-matched, time contact matched standard of care arm that focused on online health information seeking. Okay, so the ways in which stigma were impacted for this study focused on a structural piece, which I consider, in this case, modifying the environment. So the hypothesis was, if you can provide individuals with at-home HIV testing with a counselor via video chat, does that give individuals more of a sense of control? So in our formative work, we know that individuals will report things like they don't want to show up to a site because they're worried about who will they see? What if someone recognizes me? What if I feel panicky and I want to leave? What if I feel uncomfortable and I want to leave? I don't want to be in an environment where I'm like learning this information and I feel like things are potentially out of control. So the idea of basically modifying an environment to address stigma was that if we can do this, maybe individuals will be more likely to show up to their testing appointment. And so that's exactly what we did. That was one of the arms, was to manipulate showing in person or taking tests via video chat. And then we also provide stigma-focused counseling. And the stigma-focused counseling is very much focused on emotional barriers to testing for HIV. It's very easy for individuals who have concerns about testing for HIV. It's very easy for them to go to a place where they talk a lot about the logistical barriers to testing. But the reality is that, at least what I've experienced, is it's much harder to talk about the emotional barriers. And it's hard because it ends up leading to, at least to people having to talk about prior times of experiencing mistreatment. So in that stigma-focused counseling, we assess and discuss factors known to be drivers of HIV-related stigma. We evaluate concerns around stigma. We discuss prior instances of stigma relating to healthcare. And we also work really hard to promote resiliency, beliefs, and positive adaptation. A lot of what we focus on is what I call healthcare agency. So there are individuals who will show to a study and they're like, I don't care what anybody throws at me, like I am getting my healthcare. I am going to go in and get what I need. But then there are other individuals who are very reluctant to do that. Hang on, let me just check the chat. Okay, sorry. So the focus of it is instilling a sense of healthcare agency is really the primary focus, and through this stigma lens. Okay, so when we do that, so here's what we found, and I just kind of like quickly go over that. There are a lot of different outcomes, but in the interest of time, I don't present everything. But basically, what we found were some pretty interesting outcomes. One is that offering participants to take tests online increases the likelihood that they'll actually show to an appointment. So this has important implications. I mean, if you consider like a clinical setting, yes, you might have individuals who only want to take a test in person, and that's great, continue to offer that option. But in all likelihood, you will pick up, based on these findings, you'll pick up more individuals who are willing to get tested, but they want to do that at home. So we did observe an increase in the likelihood of people showing to their appointments. Now the counseling outcomes weren't as straightforward. So when we look at the stigma counseling, we didn't see an impact of the stigma counseling specifically on HIV testing uptake. We didn't, so that was a null effect, but we did see an impact of stigma counseling on self-reporting of starting PrEP use, which of course is, in many ways that is the goal. And that finding was specific for individuals under 30. And also in reduced rates of depression. So these individuals reporting lower rates of depression if they received that. And they were, and that's relative to the standard of care arm. So there was so we're still kind of unpacking it, but there are definitely some interesting findings. It's definitely some interesting and exciting findings in regards to both arms. The other thing too that we're still unpacking that it's just a lot for me to work through. So individuals who were in the at-home arm, they were more likely to test positive for HIV than individuals who were testing in office. And so, and it wasn't a small number. So 15% of individuals receiving at-home testing appointments tested positive versus 9% of those receiving in-office appointments. And what's interesting here, I mean, it's hard to say exactly what's going on, but it's possible, and I'm definitely speculating, but it's possible that individuals who were concerned about the possibility of testing for HIV were more likely to test at home because, again, like there's more control, there's less concerns about potentially stigmatizing experience. And typically people run these tests in their bedroom. So we're doing this appointment with them while they're sitting on the bed, or maybe they're in their kitchen. So they're in an environment where there's much more control. But anyways, the point is that it's possible that individuals who are really concerned about testing HIV positive might be more likely to test for HIV at home when they know that there's a chance that they could test positive. So again, I'm speculating, but I think there's something really interesting here. Um, Oh, sorry, just to answer Teo's question, can you describe offering online? So when we recruited participants, so basically we recruited 480 participants, and they were assigned to receive their appointments with us. Either they were assigned to show up to our office at a specific time, or they were assigned to have a virtually scheduled appointment, and we would mail them a test kit, and that couldn't be altered. You couldn't say, no, I want to do this in person. Like, and there was nothing to stop individuals from going to testing at a different clinic, but for us, that was the only way we offered appointments. Now you might say, well, what do you do? Then COVID hit. Yeah, COVID did hit in the middle of this, and it caused multiple problems. And so I'm only showing data up until March 13th, 2020, because the fact that the mayor shut down the city of Atlanta meant that we could no longer offer in-person appointments. So we were still collecting data after COVID hit, but I don't show that here because that stopped that arm. That we could no longer evaluate that arm. Okay, and I just want to double check. I'm not sure how often I am if I'm running.
Lisa, if you want to, you can take 10 more minutes.
Okay.
Yeah.
Okay. All right. I think that's plenty too. Okay, let me just get back on track. Okay, so that was project. So that's just the kind of a quick summary of Project Link, one of our large stigma focused trials. And then we also have Project Jumpstart, which is a smaller, it's an R34. Similar in focus. So here we also used a stigma focused counseling approach, but in this case it was specific to starting PrEP. So it is kind of like the continuation of what we saw in Link, with the stigma focused counseling being having an effect on self-reported PrEP uptake. So we looked at that relationship in Project Jumpstart. And what we also did in Project Jumpstart was we did more of like a gradation of intensity of intervention. So in Project Jumpstart, there were 4 arms. The first arm was just linkage to PrEP services. The second arm was linkage plus a stigma-focused counseling session. The third arm was linkage plus counseling plus text messaging support for individuals to access PrEP. And then the fourth arm was the linkage plus the counseling plus more active phone call check-ins to determine the additional support that individuals may need. And what we found here, so we found some interesting results. So what you see here is, so this is the, basically this is the percent of, on the left side is the arm. So it's your arm 1, arm 2, arm 3, arm 4. And then on the right side, the percents, this is the percentage of individuals who actually ended up connecting with a PrEP provider. And you see, so even, I mean, with the referral alone, we have 24% of individuals connecting with a PrEP provider, but you see this kind of stepped improvement that matches this stepped up intensity of our intervention arm. So when we do the linkage plus the counseling intervention plus phone call check-ins, we actually do see the highest percentage of individuals accessing PrEP during the follow-up, which was a 4-month follow-up period. And we actually also did Urosure biological confirmation. So this is a urine test for PrEP use. So what's interesting here, so we tested, and of course with the control arm is the smallest N, so that one is probably has less reliability than others, but we received urine samples from all the individuals who were reporting PrEP use, and we see the highest percentage of confirmed PrEP use in the most intensive arm. So it does appear that there is benefit to providing counseling support and also phone call check-ins in order to encourage individuals to be able to access PrEP. And I should say too, because you might say, well, wait a second, like it looks like, it's kind of like a minority of individuals are actually biologically confirmed with PrEP. I mean, this isn't a perfect way of measuring PrEP. So the Sure tests only really cover about a 48-hour period, plus or minus. So it's not an exact science here. And also, I know that many of our participants would say that they're using PrEP intermittently. So it's like most measures, there are benefits and disadvantages, and that's there's no exception for this one. All right, and this is my last kind of substantive slide. This is, but I think it's important, and I think that it's helpful for individuals who do intervention work. This is work that I did that Eric Leyland, who's at Yale now, who's a postdoc who has been working with me. He conducted these analyses. What he did was he looked at latent profile. He used latent profile analyses with the jumpstart participants to see the extent to which psychosocial measures, to see how movement on psychosocial measures impacted PrEP uptake. And so basically what you see here in the first figure up top, this is what the control arm participants looked like. So on the left here, so there were 7 measures, these PrEP stigma, stereotypes, negative PrEP beliefs, conspiracy beliefs, medical mistrust, PrEP barriers, PrEP social support. So we asked individuals to report on these 7 psychosocial measures. And with that, Eric was able to create these 3 categories. But then what he did is he looked at change on these 7 items post-intervention, and he looked to see if individuals were moving from the profiles that they started in prior to the intervention, and how that movement varied between the one control arm and all of the intervention arms. So for the latent profile analysis, we actually ended up collapsing over the 3 intervention arms. And what we found was that so the 3 profiles were low emotional barriers, concern for HIV prevention, and experience complex barriers. Experiencing complex barriers was more stable in control arm relative to intervention arm. So what that means is that in our intervention arm, people were moving out of, they were more likely to move out of the experiencing complex barriers into the low emotional barriers group. So that's good. Reporting low emotional barriers was more stable in the intervention arm than the control arm. So in our interventions arms, people who were in the low emotional barriers were more likely to stay there than individuals who were in the control group. And these beneficial changes were actually related to a higher proportion of uptake of PrEP use when we add that data into these latent profile analyses. So transitioning from experiencing complex barriers to concern for HIV prevention was associated with the highest proportion of HIV PrEP, highest proportion of PrEP uptake. So anyways, I think it's just, I've done a lot of intervention work, and I've heard a lot of criticisms of interventions, and I thought that this is just like a very interesting kind of novel way of assessing basically like the active ingredients of an intervention and looking at interventions differently. So I want to make sure I had a chance to tell you about that. And that is basically it. So current plans are further evaluation of current intervention outcomes. Also do a lot of costing data analyses, meeting with key stakeholders on feedback. We currently do have, we're in the year 2 of an R01 looking at where we're taking Jumpstart and looking at applying that intervention for individuals who are reporting substance use, because our substance users report seroconversion twice. They're twice as likely to seroconvert than our non-substance users. So we're using these, what the interventions that we've developed here and applying that to a substance using population. So we're looking forward to that work. And yeah, our fight isn't over. And thank you so much. So that is all I have. I'll stop sharing.
Thanks so much, Lisa, for such a great presentation this morning.
Thank you.
So we'll jump into the Q&A. Everyone, just a reminder, if you have a question for Dr. Eaton, you can either use the raise hand feature on Zoom, and I will invite you to unmute yourself, or you could simply enter your question to the chat, and I will read it on your behalf. Teo, go ahead.
Lisa, thank you. Fascinating to hear your talk and to see how you use a lot of information and build a bigger narrative. I thought it was fascinating and stimulating.
Okay.
I have a lot of questions, of course. And I think one of the questions that I had is, you had a slide where you said, you made clear that stigma is a lot of things and it works on a variety of levels, and you have to select a level if you want to do an intervention. Now, my question is, how do you select a level? What goes into that?
You know, it's a really good point. Well, I think for me, I basically, all my research has always been directly with individuals impacted by either living with HIV or potentially at substantial risk for HIV. And so that impacts the levels right there. I knew I would be working with a patient population as opposed to, say, like a provider population, just because that's not my history. I also know that, the strengths on my team are doing things like client-centered client-centered interviewing and motivational interviewing, which works well with stigma-focused counseling. And so I think for me, it's been mostly like, who do I want to work with, and what what's the background of my expertise. But I certainly think, like, people have expertise and a policy background, that should be the background that you go in. And like I said during the talk, I think that the healthcare provider focused interventions are extremely interesting and very much needed. And I think that if you have a lot of expertise in working in clinical setting, I would absolutely encourage you to do that. So I think that, I think it's kind of, in a way, it's a bit wide open, and probably based on, like, your preferences, what areas you feel excited about, and what your expertise is in. Yeah, good question.
And the underlying assumption is we have to do something everywhere.
Yeah. Yes, that is, yes. That is definitely the underlying.
Thanks, Teo. We have a question from Justin Knox. Justin, go ahead.
Hi, Lisa. Great talk.
Thank you.
You mentioned at the end there some future work with substance using Black sexual minority men. We know from our paper, right, that cannabis use was associated with increased HIV seroconversion. So in terms of that work, what's happening not only in terms of HIV prevention and linkage to care, but support for substance use, reductions, right? Because I know there's like a separate, implementation science challenge with getting evidence-based interventions for addressing those issues, actually delivered. So have you had experience or challenges doing that in this new work?
Yeah. Yes. Yes, we've definitely had, and I think one of the biggest challenges that I've experienced, because so this grant is funded by NIDA, but it's not our first NIDA funded grant. And in our prior work, I think one of the biggest challenges that we've had there is that we'll get participants situated, we'll get participants with a plan, and then the agency that we're working with loses funding. And like, there tends to be, for some, like a lack of continuity in the funding available for services, or there are changes to the funding that can impact eligibility for our participants. So yeah, it's a huge, it's a huge area of concern for us. And I mean, I think that there's a lot of awareness around these challenges, and I think there are a lot of really good people who are working in this area. But it definitely, like, I don't think I've ever done a study where it's like, oh, there's this very clear plan for how we're going to get someone impacted, someone has substance use challenges, how, what their long-term plan is going to look like for support. I don't think has ever been entirely clear, just because it is, in some ways, it's kind of like working in a minefield, because things can change so quickly. So, I mean, your point's really well taken. And I think that we've become accustomed to pivoting as we go, as opposed to like, well, here's like the very obvious plan for referral and for long-term. We can typically secure like, more shorter term plans, but the goal is always, especially because we're not working in a clinic, the goal is always to get somebody into a more, into a longer term plan. And that definitely has challenges to it.
Thanks.
Thanks, Justin. Any other questions? We have a comment from Susan Tross who says, thank you for this really powerful work.
Thank you, Susan. I appreciate that.
And we have a question from Bill Kraniski.
Hi, yeah, wonderful talk. Thanks. I'm at the HIV Center and I'm a developmental psychologist. So some of the issues, and I've talked to Theo a bit about this, but thinking about broadly, how does this work, if you've looked at age and particularly around PrEP uptake among adolescents, and how the issues there might be distinct, and then also relatedly, struggling with this idea about stigma. And obviously it's multifaceted. There's HIV stigma and stigma around sexual minority status. So, but one of the big questions I'm thinking about, maybe you have some insights, is like, when does stigma emerge, right? And how does I don't think it's static, but how does it change over time? And then what are the implications of that for interventions?
Yeah, additional great questions. So in regards to your age question, yeah, there's no question that we definitely see findings vary by age, and it's always a very important consideration in the work we do. And I think a lot of it comes down to, and let me just say this, is that we typically we just see more challenges in accessing healthcare with our younger populations, and we see higher likelihood of seroconversion among our younger populations. And in my experience, and I should say this, so in this study, we're not working with anyone below the age of 18. So in terms of like a developmental perspective, it's still like quite truncated, like, because typically our population is 18 to 30-ish, or maybe 18 to 35. But I know from our qualitative work that a lot of times it just becomes apparent that it's kind of like Maslow's hierarchy of needs, where our younger sample, or our younger participants are just, their basic needs. I mean, in addition to like the obvious basic needs like food, shelter, safety is a huge one. And I think that among our youngest sample, safety is a need that is, for many, is not met, and is leading to making decisions where putting like your long-term health first isn't prioritized, just because these other, more pressing needs haven't been answered yet. I think that, and so of course, like, there's a lot of room for potential intervention there. I think that with the, but your other question is really interesting too. And actually, Val and I, we have a paper, it just came out, we're actually very excited about it. It's in Nature Psychology. I think I'm saying that correctly. Where I actually look at so the core of the paper is really about the lack of considering time from a stigma perspective. And that area is basically wide open. So one of the things that I didn't present on here, and this is just, so there's a lot of different ways I could talk about that. But one of the things that I didn't present on here that sometimes I do present on is that when in that study that I reported on, where we looked at people who had recently tested positive for HIV or for STIs, one thing that's really interesting about it is that when we look at internalized stigma, we see that internalized stigma, particularly for our participants living with HIV, they over time, they initially report high rates of internalized stigma, but over time they report less and less and less and less stigma over the course of the study. So part of me is like, that's actually not fitting with the narrative of like, get people on antiretrovirals as soon as they're diagnosed. Like there appears to be something healing about time that we noted in the data. And so when I wrote up that paper, I basically said like, well, actually, maybe like time actually really is important in terms of like being diagnosed with HIV, but not ready to start on any ARB treatment because you're still actually working through those emotions of stigma. So the time, but anyway, I would definitely check out that article because it's, oh, thank you. Yes. Thank you, Stephen, for posting that. Because we do kind of we take this developmental perspective in there and kind of go into the importance of time. But you're totally right on. I think it's an area that was missed, and Val was smart enough to be like, we need to go into detail on this. And so she brought us together and I was like, yeah, this is definitely something that I see in our research. It's a really good question.
Oh, great. Yeah, thanks. Looking forward to reading that and further conversations, perhaps.
Yeah, absolutely.
Thanks, Phil. Next, we'll go to Charles Gonzalez, and then we'll come back to Teo. Charles, go ahead.
Thank you. That was lovely, Lisa, or beyond lovely. It was fabulous. Okay.
Oh, thank you.
My question refers to your home study test. Okay, and it's the individuals that tested negative. Were the individuals that tested negative in the clinic more likely to have moved on to PrEP? You know, trying to reverse the healthcare initiated stigma on the worried well, whether those that showed up for
Right.
the testing, whether they were more likely to be accepting of PrEP later on.
Right. No, it's a really good question. And I would have to look into that. So one of the things that, and I will look into that because it's really interesting and would help.
Yeah, because it gets into your question of agency,
Right.
How you get into, which is what we want, right? Healthcare
Right.
agency at one point. And I think that there may not be gold there, but there's something floss, you know, to find.
Right. No, I entirely agree. And I think that one thing that I really just didn't do justice, like initially, I mean, this study was planned out, and this is like, conversation for another time, like how COVID impacted like these longitudinal studies. So this study, like the way this study was originally planned out was that we were looking at 3, 6, 12 month follow-up psychosocial measures and 4, 8, 12 HIV testing uptake measures. And when COVID hit, like it just ruined, it just like dismantled my my study design. And so we ended up looking at everything on the aggregate because we didn't have the power for those 8 and 12 month markers. And so we just pulled this like hard deadline. And so what that did is that prevented us from looking at things like, well, wait a second, like, I mean, we didn't look at like prior testing's impact on like those post-testing behaviors. But we still could. I mean, I just drew such a hard line because of COVID, but like in light of like, this type of question and other questions I have, there's nothing to stop us. I mean, we could look at like the 4-month data are really complete and really are within the spirit of what was initially planned in the study. And so we could definitely look at that to answer this question. I do think, and I think it would be really interesting. I think it would, because testing HIV negative is that first step on that PrEP care continuum. And there definitely could have been something impactful about doing that at home that led to PrEP uptake. So I could see doing like looking at it as like a moderator variable. That's a really good point.
Thanks, Charles. Teo, go ahead.
Lisa, there's one word that I missed in your presentation that everybody says each time when they talk about stigma, and that is intersectionality.
It's true.
And and I want to hear, and of course you have thought about that, or you have thoughts about that, and I would like to hear some of your thoughts about that, and also whether you're able to integrate that in your study designs, or whether you feel like that's way too complicated, I focus on HIV.
It's so true. It's so very true. It's not lost on me that I don't refer to intersectionality at all. So what I have found, well, one, I found that with intersectionality, this could have evolved since the last time I looked at this, but when I initially was looking at the intersectionality literature, I thought like, for me, it just didn't lend itself to counseling, intervention, development, like these other things like motivational interviewing. The other thing that came up for me with intersectionality is comes from more qualitative work. And so in some of the formative work we do, I have introduced concepts of intersectionality. And of course, I don't show up to a group and say, tell me what you think about intersectionality, just like I don't show up and say, tell me what you think about stigma. So I would say things like, thinking about like how you experience things as a Black man, or thinking about like how you're experiencing things as someone who identifies as gay, and like how do those environments, what happens as a man, as someone who identifies as a Black gay man, like how does that impact how your actions, your behaviors and beliefs in certain environments. And what I found with participants, this is like, you can do this, what I found is that you can do this in a group setting, because you'll have somebody in that group who explains it much more eloquently than I will. And they'll like really latch on, and they'll be like, yeah, you know what, as a Black gay man, like I don't identify with LGBT culture because I find it to be really white. I find it to be really, really white focused, and that's why I identify as same gender loving. And like, then you can like have conversations where you really are like getting into intersectionality. But what I find is that like, I'll have a couple of participants who feel that way and like that really resonates with, and other participants who are just like, what? Just kind of like glossed over with it. And then I just think it becomes like too academic personally. And so, so what always resonated more with me was people understanding how they felt. Like, do other people make them feel good or make them feel bad? And that like serves as like the discussion point for stigma. That resonates really well with people. The other thing that resonates really well with people is the healthcare agency. Like, do you feel like you get what you need when you consider these emotional barriers? So that type of language seemed to resonate with more participants than language around intersectionality. So I guess like for me personally, I think from a academic environment, it's so like intersectionality is so fitting and is so critical and so important. But from like a practical environment, and when I talk with participants, it just remains something for me that's very abstract. And like when you have 30 minutes with somebody, because all of our interventions are short, because nobody's going to do like a 10-part 1 hour a piece, and that's not going to happen. We're not going to, when you have this like really brief amount of time, you need really like just clear, concise things that people grab onto quickly. And so I've really appreciated it from an academic sense, from a practical sense. I can't say that it's driven the decisions around the work, because I just have felt like these other approaches have been more user-friendly, and that more participants can kind of grab a hold of it and really process it kind of quickly, and like simpler is definitely better. Yeah, but good. This is a good observation, because I do, it is true. You would definitely expect me to be like going on and on about intersectionality, but I don't.
It's helpful to understand why
Yeah,
you didn't do that. Yeah, thanks.
yeah,
Thanks.
good question.
Our last question comes from Raymond Moody. Go ahead, Ray.
Hey, Lisa,
Hi.
great presentation. It's more just like a comment, because I really appreciate what you were saying. I think that as a clinician, I think in more like of a prolonged like relationship with the patient, who has, I think particularly like that would spend most informative of my work, like with intersectionality, about like how my patients have had to like basically parse their own identity as people based on like to disentangle that intersectional identity that they have to like navigate the services that they need. I think particularly like working with Black gay men who have methamphetamine use disorder and are HIV positive, like is like I had a lot of patients like that, where it's like, you know, AA is too white and too stigmatizing against people living with like HIV, and like the gay community, there's a lot of racism in there. And then if where I live, there's homophobia and like substance use related stigma. And so like a lot of the work that around that area was focused on like identifying sources of support, and then like skills for navigating like the emotional distress that comes with like not being able to fully be yourself in any environment, just because of the like conflicting like sources of stigma. So like really just trying to find it was, you know, in Ovid Places, you know, I think, I mean, and I've been talking to you about the K that I'm writing as well. And it's like trying to figure out how to like, I mean, one of the big driving questions of my K is like, how do we, it's like, you know, well, oftentimes it silos these people to places where they're not feeling stigmatized, but then also like it's not as conducive to the like to their health related goals, right? There's a higher prevalence of like substance use maybe in these areas. There's a higher prevalence of like, you know, of sexual or HIV vulnerability, and so it just has like, you know, those consequences, I guess.
Yeah, no, I think you know, perfectly captured it. But there, I mean, there's a lot to think through. There's a lot for participants to think through. And I think when you get into an intervention setting and you have a half hour, it can be a lot to unpack. And for some participants, it would come really natural to be like, I don't feel, you know, like I feel like this is like a white space, and I, you know, I don't feel this way, or this is like a white gay, like a space for white gay people, and I don't feel welcome there. And like, you could unpack that with a participant, but to do that with all participants who might just like not be able, they're not be ready maybe to articulate some of those thoughts, could be, that at least was my experience in our formative work, is that people are,
yeah, and I guess my point was to like in my page in this work, it took like multiple sessions just to start to like understand like what the intersection, how those different forms of stigma intersected in their lives. So I totally hear what you're saying. In a group, like it's like 30 minutes, it's not, you know, you really can't get there, but yeah, so
yeah, no, you'll have a couple of people who are like right on it, and they're like, yes, I get this, and like, and then you'll have other people who it's like, it's their first time like having thought through this. That we get that a lot. There's a lot of first in the counseling we do. There's a lot of I mean, it's typically a participant's first time that in a controlled environment they're getting like in a kind of like a slowed down, like here's your opportunity to ask questions about prevention. There's no, you know, it's and so there's a lot of things that they want to talk to us about in this. Yeah, brevity is key. You know, the brevity piece is very key and does drive a lot of the decisions that we make and how we present materials for sure.
Thanks, Ray, for your question, and thank you to everyone who participated in this morning's Q&A. Tail, turn it back to you.
Lisa, thanks so much for sharing this very rich body of important work with us and giving insights in your thoughts about it. And based on all the studies that you did, it's really fascinating to see how rich this is. And good luck with the next steps, and we'll have you back. Thank you so much.
All right, thank you all. I really appreciate your time, and I really appreciate being invited. And this has been really good. So thank you.
Okay, have a good day, everybody. Bye-bye.